Epidemiology of fibroid is very common actually. It happens in 70% of white women and about 80% of African American. Okay, and this is in USA. In other countries, it have different statistics. Okay, so it tend in African Americans. It's not just more than in white, but also tend to be younger. The patient when presented with fibroid tend to be younger. More in numbers, okay, they have multiple fibroids and heavier bleeding and severe anemia. So it's due to some genetic predisposition in African American or black women. Okay, this is about epidemiology. Now the risk factors of the fibroid is more in nulliparity, in early menarche, okay. So in anything that decrease estrogen levels, like in endometrial cancer, if you remember, we said it is more in it is more in nulliparity, in early menarche, increased age of reproductivity, because all these factors increase estrogen, okay, levels, and estrogen is a predisposing factor for fibroid and endometrial cancer. Okay, also family history is a risk factor. Alcohol, a perimenopause period is a risk factor for fibroid. African American, as I said, races, okay, and hypertension. So hypertension, alcohol, perimenopausal women, and African American, and the factors that increase estrogen levels, like nulliparity, menopause, early menarche, increase age of reproductivity. These are the risk factors for fibroid. What about the protective factors? Okay, in reverse, anything that decreases the level of estrogen will decrease fibroids. Okay, like smoking. If you remember, also in endometrial cancer, I told you that smoking is a protective factor because it increases sex hormone binding globulin, and these sex hormone binding globulins bind the estrogen, decrease the estrogen level. So smoking is a protective factor of endometrial or fibroid. Oral contraceptive pills, okay. Oral contraceptive pills actually prevent a new formation of fibroid, but may stimulate an old one. Okay, may increase an old fibroid, but prevent a new formation of fibroid. Now the most important thing is the clinical manifestation of fibroid. How does the patient present? Mainly in 50 to 60% of patients, fibroid is asymptomatic. Okay, it comes with no symptoms. But the left of patient, about 40% will present with abnormal uterine bleeding. Okay, abnormal uterine bleeding is the most common symptom to be presented in patient with fibroid. Okay, so the most common symptom. The abnormal uterine bleeding comes more with submucosal fibroid beneath the endometrium. As I told you in the first video, submucosal fibroid is the most to be presented with abnormal uterine bleeding because it embeds the uterine cavity and increase the endometrium surface area that will lead to bleeding, in addition to other, of course, hormonal factors. Okay, typically the abnormal uterine bleeding is menorrhagia, heavy and prolonged cycle. Okay, but also it may be postcoital spotting, so after sexual intercourse spotting. Okay, or metrorrhagia. Metrorrhagia is actually bleeding not during the cycle, okay? Intercyclar bleeding. Menorrhagia is cyclic bleeding but prolonged and heavy. Metrorrhagia is a bleeding during the cycle and between the cycles, okay? Abnormal bleeding, of course. So this is the first symptom to be presented is abnormal uterine bleeding, and the most common. Also, pressure effects of the fibroid will cause symptoms according to the place that is affected by pressure. Okay, pelvic pressure will cause feeling of heaviness. If it apply pressure on rectum, then we will have constipation. On bladder and ureter, we have urinary symptoms. Like what? Like frequency, urgency. In advanced cases, we may have hydronephrosis. In the cases of submucosal fibroid, if it is large fibroid, more than 5 centimeters, multiple and behind the placenta, it may impact implantation and placentation. So it may cause infertility. Most of cases, women with fibroid will not be affected in their conception, okay? So they will get pregnant normally and reach term normally, okay? But in some cases, if we have submucosal, large, multiple, and behind the placenta fibroids, we may have infertility, we may have preterm babies, abortions, cesarean section need, malpresentation, all these symptoms, okay, in case of large fibroid. So these are the most important symptoms to be presented. Asymptomatic, most of patients, abnormal uterine bleeding, and pressure effect urinary symptoms, infertility in some cases, or constipation. I forgot to say that bleeding that happens during fibroid may lead to iron deficiency anemia if it is a huge bleeding, okay? And iron deficiency anemia will be presented as dizziness, fatigueness, okay, and weakness, and all symptoms of iron deficiency anemia. Okay, so this is about the history or the presentation of clinical manifestation. What about the physical examination? Physical examination. Vital signs, of course, is important because of bleeding, to know if they have anemia or not. Okay, abdominal examination. Most of the times we will feel nothing, okay, especially if the fibroid is below 12 to 14 weeks, okay. We measure the size of fibroid according to weeks, like in pregnancy, okay. Below, in 12 to 14 weeks, the fibroid start to reach the symphysis pubis, so it will not be filled in abdomen. It's still pelvic organ, okay. By manual examination, we may feel irregular, non-tender enlarged uterus. Okay, in opposition to adenomyosis. Adenomyosis, it is regular, symmetrical enlarged uterus. But in fibroid, it is irregular, non-tender enlarged uterus, like cobblestone protrusion. Okay, you will feel it like cobblestone protrusion. Lumpy bumpy, sometimes they call it lumpy bumpy, okay? Most of the time it is felt in midline by manual examination, but sometimes it can be felt in the lateral pelvic, especially if it is large fibroid, okay? We feel most of the times the subserosal and intramural fibroid. Submucosal, it's hard to be felt by manual examination, okay? If it is lateral, then we have to put in mind other differential diagnoses that, like ovarian tumors or other things, okay? Now let's move to investigations. How to diagnose fibroid by investigations. Ultrasound actually is the most common means of diagnosis. In ultrasound, whether it is vaginal or abdominal ultrasound, we can see hypoechogenicity among normal myometrium. So it is hypoechogenicity. Okay. Hysteroscopy is also done sometimes to distinguish submucosal fibroid. MRI is done to distinguish fibroid from ovarian tumors if we have a doubt, okay? It is not routinely done, but if we have a doubt, we can do it. Histology actually is a definitive diagnosis of fibroid. You can't confirm it is a fibroid unless you do histology. So it is the only confirmative diagnosis. So these are the main investigations. This is a clinical, we talked about the risk factors, protective factors, about the epidemiology, history, presenting manifestations, okay, physical examination, abdominal, bimanual, regular, non-tender, and large uterus, okay, cobblestone protrusion, and the investigations of the fibroid. Thank you. See you in the next video talking about only the management of fibroid. This is the last, the subsequent video will be the last video about fibroid. Thank you very much for watching.